I'll bet you can't remember what biologic width is. I have a hard time remembering it. You don't really remember things that you don't use. You cut a prep, you're thinking about, I can't go too far down, I'll hit that epithelial attachment. But have you memorized that picture? That's one of the original pictures that comes relative to biologic width, and describing the attachment apparatus to the tooth. And that goes back, oh my gosh, that goes back 60 years, 65 years, that drawing. What is biologic width? I've just put a rectangle around it. It's the combination of the connective tissue, which is, as you can see on that drawing, the yellow portion of it is the subepithelial layers, and that grows right into the tooth. Can you see the enamel down there toward the bottom part of that slide? You'll see the bottom part, there's enamel. Now, the biologic width is about, depending on what study you read, 2 millimeters. It can be more in a larger person, it can be less in a smaller person, but we know that it has the attachment to the tooth through those little fibers that grow right into the cementum and therefore into the tooth. The biologic width, what's the importance of it? Why are we even talking about it? What if you cut a prep and you take off the epithelial attachment? So what? So what? It takes a long time for that to grow back. And what does that gingival tissue look like? It looks red, inflamed. If you've cut it off, it's going to have to regenerate attachment to the tooth. The epithelial attachment attaches to the tooth. The connective tissue attaches to the tooth. Many dentists kind of reject the double cord technique. If you were using a double cord on that, let's just look for a second. Here are 2 cords on the drawing I have made. And you will see where I have 1, that's the first cord. The first cord is pushed in. Down 2, you see the little black mark there, that's the epithelial attachment, and that tells you where it is. That's one of the values of it. And then that second cord is placed coronal to the first cord, as you can see. That second cord, usually we will put a styptic in it, aluminum chloride. Occasionally, if there's a little bleeding, we'll even inject a little 1-50 epinephrine in any kind of anesthetic you want to use, usually lidocaine. And what does that do? That stops any minor amount of bleeding for about 2 minutes. Well, let's continue with that orientation. After a few seconds, remove that second cord. Leave the first cord in place. And what happens? Now out comes the second cord, the first cord's in place. And what do you see? Eureka, the margins, which major labs tell us they don't even see on, I hate to tell you, the majority of preps coming into labs right now, whether it was a digital impression or whether it was an analog impression. Now, where does the crown end up? The crown's going to end up on those margins, but once you pull that second cord out, where does the gingiva go? It goes up and covers the gingival margin. In a high caries active patient, that's almost mandatory. In a low caries active patient, you could easily leave those margins supragingival, and they would be on enamel. That makes it a lot easier for hygienists to do their scaling and root planing. But in a high caries active patient, I want it halfway down the sulcus. Halfway. The sulcus is usually a couple of millimeters deep. Depends on the patient, their age, if they're using mechanical toothbrush or not, and many other factors. Because you can easily beat that gingiva down, as I have done in my own mouth with mechanical toothbrushes and paste. Well, what's the importance of biologic width? It's sacred. Don't cut it off. Leave it there. It has a reason. Thank you. Thanks for being with us. Join us next week.